Good morning to all of you. I think in the morning sessions, is always find that only brave hearts come. And we are having three very good speakers. And the first speaker is Dr. Mukund Tatte, who's been a past president of Indian Society for Surgery of the Hand and Association of Plastic Surgeons of India. In addition, his family has bequeathed a sum for an international traveling fellowship which took off from last year. He has been working at Wadia Children's Hospital, which is a charitable organization for children surgeries. And he has been very interested in the brachial plexus and nerve compartment syndromes. So here, he will be speaking to it this morning on carpal tunnel release intricacies.
Thank you very much, Chairman. It's a privilege to be asked to take this masterclass. So I'm going to speak on carpal tunnel syndrome, intricacies in diagnosis and open surgical management. I don't think there are a whole lot of intricacies, but for the younger colleagues in this audience, if at the end of this so-called class, if I can give them a protocol to do standard operations, it will have served the purpose. So I bring you greetings from Bombay Hospital. Carpal tunnel syndrome is the commonest entrapment neuropathy. Involves the median nerve in the wrist. All of us know this. And basically things that alter the balance between the volume of the tunnel and the volume of the contents is what causes it. But those are called secondary carpal tunnel syndrome, and I have listed the most common causes over here. Fracture radius, rheumatoid, hypothyroidism, pregnancy, repetitive strain, highly disputed in many studies though, and workers using vibratory tools. This I learned firsthand while doing a fellowship in Indianapolis, where they did a landmark study on 18-year-old auto workers using vibratory tools and showed that within 6 months of joining the company, they were showing symptoms of median nerve affection. Where there is no specific cause, it is primary carpal tunnel syndrome. This is the commonest, and typically women in the age group of 30 to 50, I would extend it up to 60, are the ones affected. And this is the physiology. Starts with a compression, then venous backflow, then a swelling, then altered conduction, then a breach of blood-nerve barrier, increased connective tissue and protein deposition, myelin loss, ischemia and loss of conduction. This is how it goes from mild to extreme. And I think these are the 6 things one must look for clinically to diagnose carpal tunnel. Numbness and tingling, nocturnal sleep disturbance, one of the most pathognomonic signs, weakness and or atrophy of thenar muscles, a positive Tinel sign, a positive Fallon's test, and a good loss of 2-point discrimination. I personally always do an electrophysiology, partly for medico-legal reasons and partly to make sure I'm not missing anything else. For example, just last week I saw a person who, to me in the beginning looked like carpal tunnel syndrome, did not give me full history. The electrophysiology came back pointing to a generalized peripheral neuropathy. I then insisted upon him telling me more, and then he admitted he had uncontrolled diabetes, which he had refused to tell me in my first interview. So, it might look like carpal tunnel, but it could be generalized peripheral neuropathy. And our electrophysiology department tries to see if there is additional carpal tunnel on top of the diabetic neuropathy. If that is the case, I would still operate. But if that is not the case, then... So I do electrophysiology. Many colleagues all around the world are willing to do it on clinical presentation, especially in those places where there are enormous waiting lists to do electrophysiology. I am fortunate I can get electrophysiology within 1 day of my request, so I don't have that problem. These are the clinical examinations. So the Tinel sign, then this is the Fallon's test, this is the territory, and this is how we elicit abduction. Also look for skin changes, as I have shown over here. There are very, very classical skin changes, typically index, middle and thumb, which shows dry, cracked skin. So the approaches are three. One is the extended carpal tunnel release, which is the old classical technique. Then the minimal access open technique, very small incision on the palm. And third is the endoscopic. In my biased opinion, there is no great advantage to endoscopic. This is the extended. I use this only for synovectomy. And if the patient gives a history that he or she can't make a fist, in addition to classic symptoms of carpal tunnel, strongly suspect synovium. Nowadays we have very good MSK ultrasound. So preoperatively we check for the synovium and confirm that, so that we can counsel the patient that we will not be doing minimal access. We'll be taking a bigger incision so that we can do a proper synovectomy. So first the palmar. Why the doing the extended approach is excellent for your trainees to see what you are actually doing in the minimal axis. So palmar aponeurosis, fully exposed now. Then you see the roof of the carpal tunnel. Then here you see the cut edges of the roof of the carpal tunnel and cut edges of the deep fascia of the forearm, so that you have released it fully, including distal forearm. You can see the median nerve below. That's the motor branch. And then you start taking out the synovium like so. Now the minimal access which we routinely do is being shown here, which is a very small part of the incision of the extended carpal tunnel. I have used it on hundreds of patients and I have never yet had a problem, except one case where my trainee accidentally cut the motor branch of the median nerve. We saw it as soon as it was cut. We repaired it immediately. And it was so close to the muscle that within about 2.5 months the patient regained the opposition, thankfully. But in all these years, only once. So the incision is made on the radial aspect of the fourth ray. We make a small incision, about 2 centimeters. It stops at least a centimeter short of the wrist crease. As soon as you cross the wrist crease, you get a hypertrophic scar with the movement. And therefore, always stop short of wrist crease. So step 1 is cut dermis and fat. Step 2 is put 2 cat's paw retractors, pull hard and you will immediately see the palmar aponeurosis. Step 3, plane between aponeurosis and subcutaneous tissue, proximally and distally. Then you cut the superficial palmar aponeurosis. Then you expose what are called distal holdfast fibers. This structure has been described by Japanese colleagues. I cannot say their names properly, but in the late 90s. And this is a structure over and above the carpal ligament. Always release that. Then we put the retractor proximally, exposing distal forearm and cut the continuation of aponeurosis there, and the same thing distally. After cutting the distal holdfast fibers, you start seeing palmaris brevis and thenar muscles, and you can tease them away. Clear the distal holdfast fibers distally also. Then again we create a space at the level of the roof of the carpal tunnel, proximally and distally. And then we open the roof of the carpal tunnel, as the slide on your right shows. So this is the tunnel opened, fully opened in the palm. Distal forearm fascia can be seen if you put a retractor. And then cut the junction and advance in the distal forearm. This is all under vision. There is no blind procedure here. This is the full open view, carpal tunnel, and you can just about see, it's very difficult to take a picture of this, the distal forearm fascia. And we complete this distally. How do you know it's complete distally? As soon as you see the palmar arch. Palmar arch signifies completion. And then you see the flexor tendon. If you see the flexor tendon so nicely, it means synovectomy is not required. And you see the motor branch. Always demonstrate the motor branch to your colleague. We use Vicryl Rapid for closure, so there is no suture removal. For 48 hours, we give a cock-up slab. Now the issue arises when there is thenar wasting. And there is this huge argument in ISSH meetings year after year. Is primary opponentsplasty justified? See, now this person has lost opposition. He's just doing FPL functions, showing no opposition. So I went through literature. The older literature, people like Guy Fouché, they propose simultaneous opponentsplasty if there is good amount of wasting. So did the great William Littler, but that is in the 60s. More recent literature has started showing that even elderly patients had significant improvement in the motor distal latency and sensory variables. This paper is a very good paper to decide. So opponentsplasty may not be necessary in patients with second lumbrical distal motor latency of 8 milliseconds or less. If it exceeds 8 milliseconds, primary opponentsplasty is justified because then recovery is unlikely. This is a very good paper from Japan. It's in Muscle Nerve, a journal we often don't read. My electrophysiology colleague shared this with me to give me a guideline about. And our own Garg and Kotwal from this country, in their paper they concluded patients suffering from severe CTS with thinner atrophy showed promising improvement following release. So like the Bard said, to do or not to do. Personally, I never do primary opponentsplasty, almost never. I have seen almost all patients recover opposition between 8 months to a year, including one lady with a history of 22 years who refused an opponentsplasty. Opponentsplasty added has cost and time implications. So currently, if I get an electrophysiology report like this, right median nerve severe to extreme involvement and terminal latency of second lumbrical is greater than 8 milliseconds, then I consider doing a primary opponentsplasty. And which one do I choose? I choose the Kamitz procedure, where I expose the palmaris longus in continuity with the palmar fascia. And you can see here it has been lifted up. Over here you can see I have kept it on the side. And I want you to see these 3 lines I have drawn. My friend Dr. K. Sridhar from Chennai, who is a wizard of biomechanics, he once showed me these 3 lines. This is the axis of the APB, this is the axis of the OPB, and this is the axis of the FPB. And you have to see if you have a pure median palsy, a median ulnar palsy, or a median ulnar with radial palsy like some patients have, and then decide which axis you are going to take. Now in this case, when we do Kamitz, it is typically a pure low median palsy caused by compression. Therefore, I personally prefer the OPB route so that I get simultaneous pronation of the CMC joint. So then I make a small hole in the radial leaf and take the palmaris through it. And then I use the OPB route, and if you see the tension adjustment, the pulp of the thumb is now facing the pulp of the ring finger. And this is how it looks. That's the incision. And very reasonable function can be obtained. So my conclusion is minimal access open release is as good as endoscopic. The risk of complications is far lower. You can either take a separate transverse wrist incision for synovectomy, or as I showed, take a extended incision. And in exceptional circumstances, I do a Kamitz procedure simultaneously. I do not prefer primary opponentsplasty. In my experience, thinner muscles almost always recover. And interestingly, patients are often unaware of their loss of opposition. That's the most curious part. I thank you for your patient hearing and the team ISKCON for giving me the opportunity. Are we to take questions or no?
Thank you, Mukund. I think you have about 1.5 minutes we have got. Any questions from the floor? Yeah. Run up.
Oh dear Selva.
Sir, when you sent for the nerve study,
yeah.
The result came as it's a generalized neuropathy, but usually we'll be focusing only on hand. No, how come the result?
So when our people do the electrophysiology, they always look at other nerves almost always. And if they find other nerves are slowing or showing poor amplitude, then they do a complete body study.
Oh.
So it depends on the department.
Yeah.
Yes, sir.
You have mentioned the classical test for the carpal tunnel diagnosis. Just wanted to comment on a couple of tests, which is, I believe at least, ultrasound of the nerve regarding diameter.
Ultrasound of the?
Median nerve.
Yeah.
The carpal tunnel regarding the diameter.
Yeah.
And second is the scratch collapse test. And I just want you to comment on this.
So I have never done the scratch collapse test, although it seems to be popular. I sometimes do ultrasound. Usually the electrophysiology is conclusive, but for two indications I do ultrasound. One is if I am suspecting synovium, if the fist is not complete, and two in almost all male patients. Because male patient getting a carpal tunnel, usually there can be another secondary cause like a ganglion or a cyst. So better to know in advance, therefore we do an ultrasound. But routinely for a so-called primary carpal tunnel in a 40-year-old lady with 2 kids, I will not do ultrasound. It adds cost. So.
Thank you. We'll move on to the next paper. Okay. I invite David David from Australia to speak on talking to parents and children about congenital hand differences. I'm sure no. Yeah. Alphonse wanted to ask you, so you could ask now.
Good morning. Thank you. Thanks, Raja, and thank you very much to the organising committee for inviting the Australian Society to participate in the meeting, and thank you for asking me to give this talk. I have no financial disclosures, but I will disclose this is personal opinion and things that I've learned from both mentors and my own experience. I work at the Children's Hospital in Melbourne. We've got a fairly diverse population with a number of different ethnic and cultural groups, which is, I think, important in terms of broadening your perspective. So children are different. They are dependent on their parents and guardians for their physical and psychosocial well-being, and for the most part, they're dependent on their parents for decision-making and particularly consent. As hand and upper limb surgeons, we treat children with a broad range of conditions. Each of them present their own challenges to the process of diagnosis, decision-making and consent. But today we're focusing on congenital difference, which is, I think, fascinating and challenging. So for the children and their family, their view and their reaction to their limb difference will be influenced by not just the diagnosis, but also a broad range of factors, including their age and development, comorbidities, that both physical, mental health, that will impact upon not only the treatment plan, but also their perception of the condition. A family history, that can be a double-edged sword. It can be useful to inform the family, but also it can lead to preconceptions as to which way they're going with this, and that can actually be more difficult in some ways. Cultural influences are important, and they can affect the family's perspective on their child's condition and your treatment recommendations. And the response of their peers can be difficult to predict and manage, and part of your advice to the family will be developing strategies to deal with this. And then finally, the socioeconomic status of the family, and that's important, and it's been demonstrated in a number of papers that the capacity for families and children to cope with these congenital differences is significantly influenced by their socioeconomic status and resource. So during consultation, there are two people in the room, or two lots of people in the room. There's the child and there's the family, but you also have to consider the people who aren't in the room. You've got to consider the effect of the extended family and the community. I think that's important because that obviously informs the parents. And I think you also have to think about the future adult, or where this child who's sitting in front of you, who's in the pram or being carried, is a year old, but you've got to sort of cast your mind forward to when they're an adolescent and adult and what's the best for them. So a consultation has got a number of components. There's the assessment, both of the child and the family. There's the provision of information, and it's important to understand the priorities of your priorities and the family's priorities. And at the end of the day, you've got to come up with a recommendation for whether that be treatment of any form, surgical or non-surgical, and the sort of follow-up schedule that you would envisage. And I think it's also important in these days of importance of registries and data collection to take advantage of that period, to that consultation to introduce that idea. So for assessment, this takes time and needs a relaxed environment with children. It's not something that can necessarily be done across a desk. You can't examine a child thoroughly, particularly from the perspective of their active movement. You've got to watch them play and assess how they do that. And you can also gain something by watching how the parent reacts to their child. And ideally, in depending on the environment, you would benefit from at least having interpreter services, if not psychology support available. So the information you provide, we imagine ourselves to be very skilled, incredibly knowledgeable. We know all about this, but we're coming to this consultation from a different place from the parents. So Limley Walls Group from St. Louis did a qualitative study interviewing parents and surgeons, and it was quite interesting that the difference between what was viewed as the priority in terms of a consultation. So parents prioritise what the diagnosis is, and they want to know what the treatment is, and they want to know when it's going to start, and they want to know what the outcomes are. Whereas surgeons, they're more about the underlying molecular biology and developmental biology pathology of the condition and the psychosocial impact that this may all have on the child and the family. So I still cover those issues, even though they're not viewed by the parents as important, because I think it does add to the information. But I leave plenty of room I make sure I cover the things that the parents want, and I leave a lot of room for questions, because there will be questions. And I think that's even if they don't come out during the first consultation, you give the parents the permission to compose questions and get back to you and revisit that. Parents will seek information from wherever they can, and that can be these days from the web or else the broader community, both parent support groups and their next door neighbours. And that can make life more difficult for us, because that's an unfiltered information source. But the parents are going to do this. They're going to go do research and explore, and they're going to come to you with questions and preconceptions perhaps based on that. So in terms of treatment or recommendation, forming a recommendation, at the end of the consultation, I think you've got to come up with a plan. That parents want to know that you know what's going on and that you've got an idea, because they've got no idea, and often by the time they've reached a specialist surgeon, they have been told, oh, we don't know what's going on, we don't know what this is, we don't know what this is. So they really need to reach the point where they've met the person who has the plan and has the knowledge. So I think you have to come up with a recommendation. And that may be difficult, because a lot of these things are pretty complicated, and it's okay to acknowledge the complexity, and it's okay to defer the intervention, but you've got to explain that to the parents. I think they've got to leave the room feeling that this person knows what's going on, and even if it's complicated, they know why you think it's complicated. And part of that recommendation is timing, and that's an important issue for the family. They want to plan. So the decision as to when and what you do is going to be family or patient and diagnosis dependent. And if you look at it a little further, and this is all personal opinion, this is what I do, and it may not apply to your practice for various reasons, but this is what I do. So between birth and 12 months, I do life or limb-saving surgery. I do surgery that I know that if I don't do it early, the outcome's going to be worse. But in terms of elective surgery, I defer that based on the technical challenges, anaesthetic risks, and also to give the family a chance to adjust to what's going on. I think the sweet spot, if you like, for elective reconstruction is between 1 and 3. This age, surgery is usually feasible, anaesthetics are safe. The family's reached a point of understanding, hopefully, and acceptance, and they're keen to proceed before the child becomes more aware and less compliant. 3 to 8, or approximately, is more challenging. Children have got increased autonomy, but they don't understand what the consequence of that autonomy is. They have an increasing perception of the fact that they're different, and there's increasing anxieties and phobias which make management more difficult. So during this period, I just do simple things, nothing that's going to require complex rehabilitation, and I wait if I can. And then 8 to 18, now we're getting some understanding from the child. They're beginning, hopefully, to accept their difference, and your anxiety, you can begin to manage that with some more strategies, psychological support, and etc. And this is when I'm trying to get everything done so that by the time they've reached, in our community, 18 is when they're regarded as reaching adulthood, and I'm trying to get it all done before then. So to proceed, you need consent, and it's complicated. And when you've spent a lifetime gaining experience and knowledge, it's probably naive to believe that you can transmit that level of competence to the parents during a 15-minute or 30-minute consultation. Because these people are anxious, they've got fears and anxieties, perhaps guilt, and it's a difficult interaction. So ideally, the parents are happy to take on responsibility decision making on the child's behalf, and the surgeon's role is to provide the information, recommendation, risks and complications, and provided everybody's happy and lined up, you can reach an end point such as this reef knot. It gets complicated when the parents can be struggling with their personal reaction to having a child with a limb difference. They have difficulty in accepting the diagnosis and its implications, and particularly they have anxiety about making a decision on behalf of someone else. Yeah, these people can often decide about their own fate, but when you ask them to make a decision about their child, they are sort of paralysed by that uncertainty. And then it can get even more complicated if there's conflict. So if the parents don't agree with your decision, that needs to be pretty carefully managed. I think we need to recognise our own biases in terms of our advice, and we have to be careful not to pressure parents on the basis of our own bias. So in that situation, I'll certainly use second opinions. Hopefully, meeting other children's a bit complicated, but so that can be organised. Psychology, counselling, and time. If there's a clear risk of harm, so in tumour cases and that sort of thing, then you can escalate that to taking over guardianship of the child, but obviously that's pretty complicated, and that's going to make a mess of any future relationship you want to have with the parent. Conflict between the parent and the child is also difficult, especially in the adolescent, where certainly in Australia there's a recognition of the mature minor and their rights, and there's this concept called the Gillick competence, which is something derived from UK law, where the child can, even if they're strictly speaking less than 18 and unable to give consent, their consent needs to be obtained. And then the last part of the consultation is follow-up. And so once you've obtained consent, you've done the treatment, and then there's the follow-up, there's the acute follow-up, and then there's the ongoing follow-up after that. And I find that to be sometimes challenging if things haven't gone as well as we'd hoped, but often quite rewarding. You get questions from both the parents as to what happens next, etc., and you get questions from the child, especially as they grow, and you might get some feedback from both the parents and perhaps more honestly from the child as to perhaps we're not quite as clever as we think we are. But I think it's invaluable as that informs your experience. And I think maintaining that continuity is part of the attraction of treating children, because that's how we improve ourselves, and we can even sometimes find some reward out of that. Thank you.
Thank you, David. You also finished on time. I think today finished earlier on time. So I think we'll have plenty of time for discussion, not only for David's paper, but also Mukund's paper. We're asking for questions. To start off, you said for lengthy operations, you will not do it below 1 year. So what is your time limit? What is your lengthy period?
I would, so we do, so for example, plexus reconstruction, it's a lengthy operation, and you do that at 3 months or whenever, So I'm happy to do that sort of surgery early, but for things like digit reconstruction with toe transfer or even pulsization, complex syndactyly, I would defer that. Personally, I would defer that until the child's at least a year of age. I don't see the advantage in going too early, because technically it's more difficult. You're dealing with smaller structures, harder to be precise. And I think there is some value in, for the child, I'm not sure it makes a huge difference living with their hand difference in that first year of life, but it gives the parents a chance to sort of acknowledge where their child is and accept that, because nothing's perfect. Nothing we do is perfect. So we can't make things perfect. And so I think it's important for everyone to sort of have a very solid concept of where they're starting, so that they're content when they finish.
Any questions on the floor, Mukund?
So I liked your point about the child's consent. So the bioethics guideline in India is verbal assent between 7 and 12 and written consent between 12 and 18, even though not legally adult. Do you have similar in?
No, we don't have a requirement for a written consent. And to be honest, we don't. It's more an individual a judgment as to whether the child is consenting or not. But there's certainly an acknowledgement that the mature minor, and that's not strictly an age thing, that's based on their comprehension, social circumstances, but there's an absolute requirement that they're on board.
Sir,
Alf?
I have a question. Yeah.
Alf?
Thanks, David. Nice talk.
Thank you.
I like your comment about the 3 to 8, right? Where you find that they sort of know something, but they don't know enough.
Yes.
Haven't come of age. What would you do with the patients that present with congenital anomalies that late, right? They come at 4 or 5. Do you defer those kind of surgeries until after 8, or you go by case? Or?
I think it's case by case, but I would probably, if it's something like a thumb reconstruction where there's clearly a functional advantage in restoring thumb function, I would get on with it. But we're pretty fortunate where we are that we see that sort of presentation is relatively uncommon. But I think if they're at the age of 4 to 5, the child's going to school and you really need to do something to make their hand functional and acceptable to them. So I would break my rule and do something serious.
Thank you.
Yeah, sometimes we face the patients, the parents are not ready for surgery. The child who's in pubertal age is ready for surgery. The parents, in spite of being affording, somehow they just try to avoid surgeries. How do you deal with such?
I think that's hard, and I think that's where I think probably, if we are honest about it, while we would like to do a polycisation, for example, between the age of 1 and 3, perhaps, the child who has a pulsation of 4 probably does okay. And if the parents are on board by then that's going to be a much better outcome. Yeah, if the parents are accepting. Because the problem is that if you have I feel, if you have a problem and you've pushed the parents into it, it's going to just be a very long and tortuous and an unpleasant journey. And as I was saying, I find personally the rewarding thing here is this is birth to maturity. This is a 20-year experience with the child. And if you start off on the wrong foot, it's just going to be a long, very bumpy. So I think I would wait until I can get the parents on board. And if I guess that's where it gets difficult, is if you feel that the child is actually being harmed, the future child is being harmed by the parents' intransigence, then, and you can't get past it, that's, I guess, where the guardian thing comes in, but that blows up your relationship. You're not coming back from that.
It becomes very difficult. I always try to put off these surgeries then, because the child keeps coming.
Yeah, I just see them. I say, okay, if you're not ready, we'll see you in 3 months. If you're not ready, we'll see you in 3 months. And eventually most of them come around.
Thank you so much, David. There's someone who was asking you one question for Mukund. You?
My question is to Dr. Mukund, sir. So how much of faith do you have in the electrophysiology in carpal tunnel? Very often I've come across that it is labeled as carpal tunnel syndrome, and when we do a clinical examination or follow it up, we find that the problem is lying somewhere else. And depending only on the electrophysiology and not doing an ultrasound or not doing an MR, which is considered now as MR neurography, which should be a standard for documentation also. What would be your opinion on this?
So a well done, I'm stressing on well done. A well done electrophysiology differentiates between carpal tunnel, proximal radiculitis, anterior horn cell, generalized neuropathy. Everything is differentiable. So as long as you trust your lab and the intelligence and the knowledge of the people in that lab, electrophysiology is more than enough. My colleagues in the UK NHS tell me they just do it on clinical grounds. They don't even forget MRI and ultrasound. They don't even do electrophysiology. So there are different strokes for different folks. But in my unit, electrophysiology is a very high standard, so I trust it implicitly.
But maybe the message we could give to the audience.
Clinical, number one.
Clinical.
Number one, clinical.
Yeah,
clinical is very convincing.
Yeah, clinical.
But if there is diabetes or hypothyroidism, then be very careful before your final.
Yeah, I think that's the one. And it's not that, if you just do clinical, you'll be held liable in a medical court or something. It's not the thing that you have to take back the message. So you can judge your clinical judgment and still go ahead. And you'll not be held liable because you do not do an MR neurogram or ultrasound or this thing. I think we'll go on to the next paper. If the next person finishes faster, then I will have to, please. And now I'll request Alphonse Chong from Singapore to come to speak on development of hand function in children.
Good morning. Thank you very much for the introduction. So it's a pleasure and honor to be able to speak today at the Masterclass on this development of hand function. So the function of the hand can be considered on a spectrum, sensory-motor continuum. On the left-hand side are the pure sensory functions, tactile and active haptic sensing, and on the right side are the motor functions, prehension and non-prehensile functions. I think it's also important that to remember the hand and the upper limb contributes to a person's body image. So the next couple of slides, I will discuss these functions in turn. So tactile sensing is what we usually think of for sensory function: hot versus cold, pain, 2-point discrimination. In active haptic sensing, the hand is moving, like this picture which I show, So we are using more than just the skin sensors. There are also receptors in the muscles, tendons, and joints. And in this way, more information can be gathered. So like you're feeling a pulse, palpating a wrist, are all examples of active haptic sensing. So next is prehension, and I think prehension is what hand surgeons always think about when we talk about function. And it is one of the functions that is commonly impaired following injury or disease. So here are 6 commonly used prehension patterns. And so depending on the size, the shape, and the goal and the weight of the object, we use different patterns. But even though we talk about grip patterns, I think it's helpful to know that there's a variation, right? And this video I put up just demonstrates even something like writing, holding a pencil, that there are a lot of variations. Actually, the variations to get the same job done is useful, right? It allows opportunities for adaptation after injury or disease. So there's a blog here on the ASSH website that suggests modification of grip when the patient has difficulty with the original pencil grip. So this image montage are just some examples of non-prehensile function. They can be grouped into gestures, pointing, keyboard skills, and bimanual skills like music skills. Lastly, I think we need to remember that the hand has an important function as part of one's body image, and a normal hand contributes to a person's psychological well-being. After the face, the hand is probably the most exposed parts of most people's bodies. And beyond just exposing them, they are often adorned with jewelry or other accessories, or even decorative painting like this here. So in congenital upper limb anomalies and following injury, there's not just loss of the usual sensory motor function, but it can affect the body image, which in turn influences whether the patient will accept it and use the limb. So because of this, I think there's a role to restore appearance of the hand and limb following injury or disease. So in our hospital, we started an anesthetic prosthesis service, which has been there for many years. It started as a research project by Professor Robert Fo, who was our pioneer in hand surgery, and now it's a self-standing service for Singapore and beyond. So we are the only custom aesthetic prosthesis service in Singapore. And this quote I like from our chief prosthetist, who said that sometimes the functional deficit in terms of the motor and sensory is minimal, but the psychological and psychosocial impact from disfigurement is worse. So our service was recently profiled on our national newspaper, and you can see it online if you like. So just one example of a symbrachydactyly patient that we had, where whole hand prosthesis gave this particular patient the courage to change professions to become a property agent. And now she said that she has the self-confidence to meet prospective clients, and she has been using this prosthesis. So that's the prosthesis on the right hand for more than 9 years. So with the understanding of the functions of the hand, I like to describe now the growing hand and its functional development. So I put this picture of this infant sitting on the floor, holding the milk bottle and drinking from it. But we all know that this takes many months, right, from birth. And in that time, there are lots of physiological and functional changes. So first of all, there's growth, right? Growth in the overall size of the child, but in particular, the size and the shape of the hand, right? And this increase in size allows ability for grasp. In parallel, there are important changes, right, in the nervous system. Increased myelination, and importantly, learning from sensory and motor feedback to build hand function. So I will explore this in a little bit more detail. So the first is tactile sensation. And there's limited information on the development of tactile sensation. Spatial and temporal ability peaks in adulthood. Similarly, for pressure, vibration, and thermal sensitivity, there's also limited information. But we all know, but there is information that these sensory modalities do decline with age. Active haptic sensing starts early in life. So I remember my own children, when they were young, we had this textures book, okay, where you hold a child's hand and you can move the fingers over the texture, repeating the name of the texture to the child. So in this way, the child gets exposure to both the texture and learning their names. From age 2, the child learns to manage shapes, and their acquisition of this active haptic sensing is almost complete by the time the child is 5. So next we come to prehension, which is helpful to conceptually think of it as reaching and grasping. So for active prehension to occur, you need a stable base for the body. So development of postural control goes hand in hand with the development of prehension. And we can think of development of grasp in 3 phases: birth to 5 months, 5 to 8 months, and 8 to 24 months. And I will cover this in turn. So, the initial 5 months, what we see is a lot of spontaneous body and arm movements. So this video, we see the child spontaneously moving, and this is an example of general movements or motor babbling, which are developmental precursors for reach and grasp. And over the few months, the child will adjust posture to force applied to the trunk, subsequently becoming reach-related postural changes by 5 to 6 months. So here are some examples of pre-reach movements. If you look at the top row, in this photo sequence, a 2.5-month baby is shown an object of interest. And we see the child moving the hand as well as thrusting the mouth towards the object. In the bottom row is an example of hand motor babbling, where the child alternatively extends the index finger, touches the opposite digits, and closing the thumb and index into a pinch. As the child becomes older, from 5 to 8 months, we start to see some immature prehension. So this prehension can be thought of as reach, then grasp. So it resembles prehension in the visually impaired. Right? The reach is different. It's not really so smooth. There's some start and stop. And the grasp is also different. Right? You will see the child will touch the object and then reorientate the fingers for the grasp. Between 8 to 24 months, we see maturation in this visual reach and grasp, using vision to integrate this prehension. So as an example, at 6 months, we still see this immature type reach, then grasp kind of movement. But by the time the child is 24 months, we can see that the child is able to anticipate and position the hand, and only closing the hand once the majority of the hand contacts the object of interest. But of course, it doesn't stop at 24 months. Along the way, we build on these basic foundational skills that widen our repertoire of prehension grips and application. So this is an example of how amazing prehension and motor ability is. And here is it in slow-mo again. And so visual reach and grasp. Okay. But skill skilled non-prehensile function movements are also important of part of hand function. So it can be divided into the following categories: gestures, pointing, aiming, keyboard skills, and bimanual music skills. Yeah, and because of time, I'm just going to talk about gestures. So gestures are learned behavior, right? For example, the child learning to wave, hello or goodbye, and we teach it and reinforce it to the child each time we use it. And gestures are also contextual. It can mean one thing in one culture and another thing in another culture. So beyond learning the motor part of the gesture, the child also learns the meaning behind that movement. The child with a congenital hand anomaly approaches the world with a different perspective. Right? This child adapts not to loss, but to a world that is configured for a different set of motor expectations. So for example, this child with radial longitudinal deficiency, so she has a stiff elbow and thumb hypoplasia, and her radial digits are all pretty stiff. So she approaches prehension and the physical world with her ulnar digits. So surgery can also help function, right? And this is what drives many of us to do congenital hand surgery. So this is my patient with constriction ring syndrome and acrosyndactyly of central digits. So I divided her web and some constriction rings in her other limbs. So this opened up the web space and allow her increased web span and individual finger digit movement. So it's a pleasure to receive this video. Actually, this video is from the mom with a note saying that, thank you, that the child is now able to hold her own milk bottle. So to summarize, for those of us who are treating the hand, particularly the children, I think the hand has a variety of functions. And while we think of it in terms of sensory and motor, that it is useful to consider them in a continuum. And the hand also contributes a lot to the body image. In the growing child, the development of hand function depends on concurrent development in many other areas. And when there's loss or disease, I think we should not underestimate the ability of the child to adapt to it. And I think for us, if the parents encourage the child to try, often they can adapt much more than we might necessarily think. But of course, so surgery is also very helpful to restore function in the right patients. So thank you very much, and welcome you to Singapore next year.
Thank you, Dr. Alphonsus. Any questions from audience? Yeah. Are there any questions to any of the? Yeah, you had question. Yes, please.
My question is for Mukund sir and to the chairpersons also regarding the carpal tunnel. So is there any role of steroid injection in any stage of the disease? And like if patient already have received steroid, does it affect the surgical treatment outcomes?
Sir, first, sir.
So, long ago, I used to give steroid injections. I have stopped giving it because I'm scared of doing the blind injection. So today, my only indication of giving steroid is if patient is very symptomatic, for whatever social reasons is unable to undergo surgery, but wants symptom relief, then I refer to a sonologist for under vision steroid injection. I've stopped doing blind injection. But in general, if there is a confirmed carpal tunnel, I would prefer to do surgery because with steroid, there is a known recurrence also.
David, would like to get your idea because in the West, I think somebody is diagnosed as a carpal tunnel. I think the first line of management will be a steroid.
Sir, I wanted to ask you, you are talking about the recurrence after steroid. What about recurrence after the surgery? Have you faced recurrences?
I have not. Maybe 1 in 200. But
No,
typically, I personally think typically recurrence happens because of incomplete release.
Yes.
Not if you have done a complete release, very, very unlikely.
I had one recurrence only where there was fibrosis around the nerve, and he came almost 3 times. So,
David?
I would just a comment about recurrence. In carpal tunnel syndrome, I see quite a bit. Some of it's clearly incomplete release or inadequate release. But I do think there's a population of patients where they get fibrosis, reformation of the retinaculum perhaps, but certainly adhesion of the nerve, which restricts its extension. Its movement. And whether that's what causes the symptoms, I'm not sure, but they can be pretty difficult because once they've demonstrated that tendency, then it, as you say, it tends to come back. So I tend to try and do a fat flap to try and limit that re-adhesion. I just had a question for Alphonsus. So we were talking about kids with congenital difference where for whatever reason we haven't restored the functional components by the time of their normal development milestones. Do you think, my personal feeling is that they catch up, but do you think that's, how critical is the normal milestone schedule in development of prehension, for example, in terms of guiding us about timing of surgery?
Yeah, that's an interesting question. You're talking about physical,
physical,
like structural problems, right?
Yeah.
I find they tend to adapt as well. So I wouldn't follow the same schedule, right? Like for patients without physical deformity. Yeah. Does that? Because I feel they are a little slower, like you said, but they will find a way. They tend to find a way. Yeah.
Yeah.
I have a question for Alphonsus. You mentioned about the inadequate reach and grasp around 5 months. So I personally think their visual cortex and their vision also is not normal till 6 to 8 months. They are seeing things.
Yes.
But it's not matured. So perhaps that is also part of the reason why the reach and grasp is not as good before 6 to 8 months, in addition to the hand motor cortex.
Yeah, I think that is a good point. I think for you to reach and grasp or to do something, many things need to work well, and every month it's different. And I think for those with physical deformity, how do I say? If you know how to do something, and then you will teach your child a certain way, right? But your child structurally is going to do it differently. They need to figure it out, right? So something like tying shoelaces and all that with one hand, I don't think I could do it, but I've seen children figure out a way to manage with one good hand and one not so good hand. But they have to figure that out themselves. What do you think, David?
I agree. And so the arthrogryposis group are the kids with the amyoplasia, their capacity to adapt to seemingly, incredibly difficult circumstances, the crossover grasp and things. And so the other group is the neonatal plexus or birth plexus group, where we sort of focus on the motor recovery, but getting back to talking about the elements of function.
Yes.
We don't really talk about sensation much, and the influence of recovery of sensation in that group on development of function. And I'm sure that's why when we get bad results there, hands sort of hidden, not used, put in the, but that's a sensory element to it as well.
And David, you not mentioned about the steroids in carpal tunnel. What's the practice in Australia?
I use steroids pretty commonly. I'm happy to give them a steroid injection in the office. I'm pretty careful to make sure I don't elicit any Tinel sign at the point of putting the needle in, because the last thing I want to do is put a dose of steroid into the nerve.
So when you give steroids, how many of them don't come up for surgery later?
I don't think. Pregnancy, perhaps. Yeah, you might. The postpartum female who's got kids or got a young baby can't have surgery. You may achieve a durable result with them, but I think the rest of them, it's a 6 month.
There was another question was, does prior steroid injection give you any problems during the next surgery?
Well, I think there's evidence that if you operate within 6 weeks and perhaps a little longer, then you can have wound healing problems. So I tell patients if they're having a steroid injection, you're not having an operation for at least 6 to 8 weeks after this. So, but I use it exactly as has been discussed. I use it as a, symptomatic, but for social reasons, travel, baby, etc., can't have surgery. So I'll give them a steroid injection to tide them through.
I think one of the common things where they use steroid is both for decurrence and for carpal tunnel. I think steroid is an extensively practiced procedure in many parts, but I don't use it. But it's acceptable by many people. Yeah.
Oh, it's our first line for trigger finger.
Yeah, it's the first line of. It's supposed to be the first line of management.
Yeah.
Not
Certainly
surgery
for trigger finger and decur veins, everyone gets a steroid injection.
Oh.
Yeah, I had a question for Alphonsus.
Yes.
In the delayed presenting patients of congenital anomalies, up to what age the brain plasticity works for the readaptation to the new form of the hand?
I think children can adapt quite well, first of all. So I never underestimate the child, but that includes finding a way to do it not using that limb if they have another normal hand. So I mean, taking an example from like cerebral palsy, I think a good time to do surgery is when the child can understand and wants the outcome. Right? If you can match what the child wants with what you can deliver, you get the best result. Otherwise, you can do the surgery, but the child either doesn't want to do the therapy or doesn't want to use the limb after that, right? Because you're going to change the way the child uses that limb, and the child's got to buy into it. Right? Yeah.
Would you like to talk about it?
5 or 6 is an age beyond which things get difficult. So I once did a bilateral polycization after 6 because patient came at that time. And that girl took 4 years before she used the thumb. Then she used it normally and went on to become an engineer and so on. But for 4 years she refused to use it.
I think it's not. The plasticity extends for a quite long time. That's one of the reasons why Paul Mansky's group, they said, when they were talking about the timing of polycization, Dr. Bakramko and team, they said impression in the brain of the thumb gets in about a year of age, and you need to do it before 1 year. But then by a long big series, they found that children who had a polycization at 3 or 4 also did equally well. Not 10 years and all that. Yeah, a little delayed, no, not necessarily below 1 year of age. Because they also did equally well, probably because also polycization requires absolute adaptation of the tensioning of the muscles and all that, and they found many of them did it much better when a child's structures were well formed. So I think a lot of things go into the thing. And one thing is that the brain can adapt for quite a long period of time, about which the final this thing is not clearly known as to how much they can adapt. The same thing for stroke people, no? So they all get injury, and then the brain injury happens, adult brain injury. So after that also they adapt.
Yeah.
So that means the brain continues to do.
So my second question to this was, is there any particular age where you decide not to operate on that patient depending on the specific conditions? That, I won't operate. No?
Yeah. I agree.
Okay, I think thanks so much for all the speakers, and we did a quite interesting session. And we'll have some tea time before we assemble for the Professor Venkataswamy oration. Please be on time for the Venkataswamy oration, which is at 10 o'clock. Thank you.